It's time to turn down the noise and tune in to News You Can Use, the show that gives you a quick insight into the latest twists and turns in healthcare news, where every diagnosis comes with an order of side-splitting humor. Your hosts are Dr. Nick, a longtime host, innovator, and healthcare wizard who can prescribe a digital dose of innovation to cure even the most ailing operational inefficiencies. And Dr. Craig Joseph, the healthcare guru who can diagnose both patient and software glitches with equal precision, making sure hospitals run smoother than a well-oiled robot doc. So buckle up, because we're diving into the ER of excitement, the ICU of irrationality, and the waiting room of wacky wisdom. Now here's Dr. Nick and Dr. Craig.
Hi, I'm Dr. Nick. I'm the incrementalist and host of News You Can Use, reporting live here at HIMSS25. I'm here with Bevey Miner. She is the EVP Healthcare Strategy and Policy for Consensus Cloud Solutions. Bevey, thanks for joining me.
It's a pleasure. Glad I'm here.
So before we kick off, tell us a little bit about yourself, your journey, how you got here, if you would.
I've been in healthcare technology for about 20 years, and I've seen this long, winding journey.
So you're still a beginner then?
Yes, I definitely am. And hopefully in the next 20 years, while I'm still around, we'll solve all these problems.
Yeah, you and me both.
Yeah.
So tell us your story as to how you got into this and how you ended up at your current role.
So when I think about healthcare technology and the original efforts we did with data sharing, having worked for one of the early health information exchanges, back then we called them RIOs, which were regional health information organizations, and the challenges we had with data that went back and forth, and the governance, nobody was paying for any of this stuff, but we recognized we had a problem. Data sitting in a silo does not follow the journey that a patient has. Now fast forward the 2 decades that we've been working on this, and all the meaningful use dollars and the high-tech money and the $1 billion that the first Office of National Coordinator
was it only $1 billion?
It was $1 billion back then when high-tech money was put into place for every state to put together an HIE, right? Mm-hmm. Failed miserably.
Right.
The governance was a lot of it. The economic models were a lot of it. Now when you start to look at the speed with which we've started to add regulations, and part of my job is policy, the talk of TEFCA, the talk of FHIR, the talk of QHIMSS, the regulations around it. There's still a lot of open-ended questions, and there's been standards of data sharing in the last 2 decades since I've been in this industry too. There's a lot of talk around, is this really going to happen? We have a change in the administration. Is TEFCA still going to go through? Is FHIR still going to be the preferred method of sharing data? Now look at an industry that is barely off of a digital or off of a dial-up fax machine, right? And now all of a sudden
Pause for huge laughter in the background.
Yes.
Go on.
Laugh. Not applause, but laugh. Is that how are you going to take that Herculean effort and all of a sudden have all different kinds of care settings, be able to share information and take advantage of things like QHIMSS and TEFCA and all the other buzzwords you want to put into place? One level above the digital fax or the dial-up fax machine is digital cloud faxing. It's secure. In our case, it's high trust certified. At Consensus, that's our flagship product, is eFax. It's the easiest way to do send and receive. Huge amounts of data are running through our platform and other platforms that do digital cloud faxing. Send and receive. Hospital can send a fax to the skilled nursing facility, to the substance abuse center. They can send a fax back. You can fax a prior authorization form. You can fax a referral form. It's done all over the place.
So step back for a second, because, and I know it's a core business, so I respect that, but it can't be lost on you that this is technology that is as old as the hills. And, I'm trying to think who it was that threw a fax machine into the shredder and said, no more faxing. And, we can all laugh at it. But the reality is it's not going anywhere. And the question I have, before we get into, deriving value and accepting, why has it not disappeared? What is it that's made it so sticky?
It's easy. It's easy, it's fast, it's secure. Send and receive, send and receive. And what I think is we are not going to get rid of even the digital cloud. Now, I think paper is starting to go away. We're starting to get rid of the fax machine.
I heard this when we got printers.
Yeah, I know, right? We're not
Paper is going away.
Right.
Come on.
We're not going to get rid of... Well, we also heard that with the paper files when we tried to get docs to get off of paper records.
Yeah, we're moving on to the PC. The paper's going to decrease.
Yeah. So when you think about cloud faxing, it's easy, it's simple. And it's not just cloud faxing that creates unstructured data. Yeah. It's unstructured. It's a picture. Period. It's a PDF. Yeah. There's scans. There's TIFFs. There's so much unstructured data.
Right.
80% of our healthcare data is unstructured. Admittedly, a big piece of that pie is images, but a lot of them are documents. So rather than try and put all these incentives in place for FHIR and TEFCA and rules that say you have to use X12 for this or that, we need to figure out how to modernize that fax process, that digital cloud fax process. We are the largest in digital cloud faxing. We recognize the problems that unstructured data has. We will attack that beast, that gobbledygook of data that nobody else wants to touch. And you go out here on the floor at HIMSS and there's a bunch of AI companies that have great workflows. They have referral management, prior authorizations, care management workflows. And I ask, what are you doing with all that unstructured data? Well, we have to have structured data. I said, you've got a lot of data sitting in these unstructured documents. Your solution can only do so much. The CDC is doing a data modernization. They're requiring FHIR to populate surveillance data. That can't happen at the small community clinic. So we take that information that's sitting in a locked cloud fax, we extract it.
How?
We use our NLP and AI solution to extract all the fields. So let's say it is a referral document.
Yep.
You've got the patient's name, Frank Smith. We give you a confidence score, 100%, that's Frank Smith. You have an address, you've got the patient's information. The AI also understands contextual extraction. So if that's a referral and the referring physician is missing, the AI will say, well, that's zero confidence. There's no field that's been filled out. And so it flags that because this is a referral. It knows that's a referral. It needs referring physician. It's also contextual because sometimes if it's handwritten or even if it's a typed written form, if the address is the same as, the patient's address, they'll write same as above. Well, the AI knows that same as above is not an address.
So actually that brings a point. I was going to ask you about this. So this is not just typed or computer produced, but this is handwritten as well?
Oh, you would not believe how many handwritten. When we look at our billions and billions of fax pages, we can see that physicians will print out a prior authorization form. Yep. They will hand write the prior authorization form and write urgent across the top, and down the side. Yep. And we recognize all that handwriting. Mm-hmm. Our AI...
You recognize physician handwriting?
Yes. We do.
I'm sorry, going back eons, that has not been possible.
We recognize physician handwriting, we recognize things like urgent, and also because it's contextual. So this is a prior authorization, it needs to be done fast. That's probably urgent. You need the code, you need the diagnosis information. Our AI is pretty accurate. When it's not, we put business rules in place that say, a referring physician is missing. So we have a work queue that says, here's everything you told us you wanted your business rules to be 80% and above accuracy. Run it through the process. Take all the data, map it to whatever workflow. Now no human has to touch it. But for these fields that seem to be missing or this document that needs to have some human look at it, we give you a dashboard that says, these don't make sense. Our AI is saying it doesn't make sense. So you need to look at it.
Well, so I'm going to challenge you a little bit because let's be frank, we're here at HIMSS25. I've certainly been heard to say it. I've said it a number of times. Lots of others are saying it. That's just hype on AI. Is this just hype?
Well, so what's interesting is that 3 years ago at HIMSS, Microsoft and Epic came out with an announcement that said they were going to use generative AI to help look at treatments.
Was this before ChatGPT?
This was, ChatGPT GTP was consumer oriented for the most part.
Okay.
So you're talking about 3 years ago.
Yeah.
Now there's this investment to say we're going to use AI and we're going to diagnose and the AI will treat a patient. The whole industry was up in arms. The talk of hallucination effects and how can that really happen? Everybody was like, whoa, this is just, no, I'm not going to have any AI actually diagnose my patients. And so here you're at a technology 3 years ago that was looking for a problem to solve. Horrible way to go to market. Then a year later, this is 2 years ago at HIMSS, or last year at HIMSS, the AI conversation started to be kind of sounds good. Hospital systems were saying, I just don't know where to put it. We have an AI strategy, but we aren't sure where to use it. Now at HIMSS, you see real applications for AI. You see real metrics about physicians that don't have to do pajama time anymore, reducing the burnout. You see extraction of data that can fast track a prior authorization, which is one of our use cases. Care management, case management, extracting all of that, ambient listening in a physician's office. Those are real examples of how AI is satisfying whatever metric we wanted to see, whatever ROI. Look at referral management. If you've got a stack of 100 referrals that came into your specialty, skilled nursing, home health, if you don't have those referrals addressed really quickly, now you have revenue loss. So if there's a revenue way it's solved, there's a workflow way it's solved, there is physician burnout it can solve, and patients can get faster treatment because the data is actually shared. What concerns me is that health equity has to equal tech equity and tech investment. So you've got the birthing center, the substance abuse center, community clinics that didn't get EHRs under meaningful use. They don't have the ability to use all this sophisticated way of sharing data, the Epic to Epic to Epic to Epic. We can leave them on digital cloud faxing, and through our extraction technology and our translation technology, we can extract that data, turn it into a FHIR message, send it on to a payer for Medicare Advantage, and meet the qualifications for the 2027 rule. That means they don't have to start to do those kinds of investments. So we make it more equitable, and a lot of my advocacy work in DC has been, we cannot ubiquitously require that every care setting have this kind of investment on interoperability. But cloud faxing, move to the next level, can actually satisfy a lot of that.
So you can have it, you just have to advocate for it in a cloud version as opposed to individualized.
Or that you now are adopting TEFCA and you put in a FHIR resource network.
Right.
Because if you can't consume a FHIR message, because you're the birthing center in an underserved area of America, and you don't have a way to map FHIR messages, you have to get information. Yeah. So you get it as a cloud fax. When you have to send the encounter data or ask for a prior authorization or look at doing some sort of, information back into a health system, just send it as a cloud fax. We'll convert it over. We map it into the health system. We send it as a FHIR. We'll work with your payers to be able to do the same thing. They can consume FHIR. You can't. Let them do what they can do today until we get health equity that has the same investment with tech equity. Then we can level the playing field. Otherwise, I had a meeting with the CDC as part of my policy work. I said, you're doing data modernization. You're requiring that surveillance data is populated using FHIR. Great. Now you've got structured data. What are you going to do with the community clinic that can't populate public health data with FHIR messages? It's going to be biased. Population health will be biased unless we can level that playing field somehow.
Well, fascinating times. I'll be frank. It's still hard for me to say, but we're going to see more in the way of faxing.
Yeah, I don't think we necessarily are going to see more in the way of faxing. Look,
I'm being a little bit facetious.
We're a publicly traded company, so our revenue is out there. We've seen growth in cloud faxing. I think that's coming from two places. One is on-prem faxes are really expensive. So systems are saying, we got to move to the cloud investment that we're making. So we want our faxing to go to the cloud.
100%. And I'm being a little bit facetious.
Yeah.
But So let's sort of digitally enabled faxing, which is sort of capitalizing on the existing infrastructure and then building on top of that with technology. Unfortunately, as we do each and every time, we've run out of time.
Yeah.
Just remains for me to thank you for joining me on the show.
It's been a
Bevey,
pleasure.
thanks for coming on the show.
Always a pleasure. Thanks a lot.
And welcome back to the live show from HIMSS25. This is Dr. Nick, the incrementalist, host of News You Can Use. And I'm here now with Neal Quinn. He is the head of cloud security in North America for Radware. Neal, welcome to the show.
Thank you, Nick. Pleasure to meet you.
So if you would, tell us a little bit about your background, how you arrived at this point, if you would.
Sure. So I've got more than 20 years experience in DDoS mitigation. I was part of the management team, the CTO of a company called Prolexic that was a front runner in cloud DDoS mitigation. So I spent a long time
forgive me, I'm going to ask you, I know, but maybe some of our listeners don't. When you say DDoS, what do you mean?
Distributed denial of service attacks.
And what does that mean?
So that means sending a flood of legitimate looking data to some sort of internet property to consume all the available bandwidth or processing resources so that it's not available to legitimate end users.
Making it unavailable to people. It's one of a variation of lots of different types of attacks, potentially, right? Okay, sorry, keep going.
So, yeah, Prolexic, we built that business up and sold it to Akamai in 2014. And I worked at Akamai for a number of years afterwards, running various teams. I ran global capacity planning for a few years. I ran a countermeasures engineering team and did some very large build-out work within that environment. Then took a little bit of time off and was recruited into Radware by a friend.
Right.
And I was a very large Radware customer prior to that as well.
So denial of service attacks on the decline?
On the increase. Specifically at layer 7, we see
again, I'm going to pause you. I know what you mean, but what do you mean by layer 7?
So at the application layer, where
we exist.
Where we exist.
Yes,
so
we humans.
Send what's called an HTTP request.
Right.
And that responds with some data, some pictures and things when you interact with a web property.
Yep.
So, and all of that is part of a overall stack that we use for communication. So when we say layer 7, we're talking about what happens at the application.
Right.
So we see those now being sent over encrypted channels, which makes it very difficult to defend against because the attack will be it'll be obfuscated by the encryption, so you can't see what's inside.
Oh, interesting. So because they're encrypting the traffic, you've got no idea as to how they're approaching it? Is that?
You can't find a signature without unpacking the data by decrypting it. So
there's no signature of encrypted data?
In the encryption, any pattern that would be there
is gone.
There are some ways to see some things, but generally you're not going to be able to see what's there unless you decrypt. And the attackers will send, and everything that you do on the internet now is generally protected by encryption standard called SSL or TLS.
And you know, to be clear, we've advocated the use of encryption to protect our data and everything, but here it is working against. So, you know, as is always the case, you can find bad uses for good technology, and that's essentially what's going on here.
So in this particular case, we saw a 500% increase in the use of attacks over that channel.
500%? That's where we're at?
Report. Yeah.
Wow.
So, and the attack is very difficult. The authors of the attack software really came out of what was being used in the cyber war that's part of the Ukraine-Russia conflict. We saw that attack software used early in 2022 to great effect, and it's able to do things that are designed to defeat the countermeasures that a typical DDoS mitigation provider would use. So things like modulating the signatures in under 5 minutes so that you can't latch on to what it is using time series data.
This sounds like the Borg, the way that they modulate and, detect and then they adapt. Yeah. That's essentially what's going on.
And the actors, they have access to some very sophisticated techniques. So they can modulate the attack signatures faster than you can keep up if you're trying to drive the response with humans. So one of the things that you do in this sort of cyber defense is deploy a team in what's called a SOC, or Security Operations Center. And that team will be responsible for managing the attack, managing the various countermeasures that you use in order to fight it. In this case, it makes it impossible for a human to isolate the signature of the attack, deploy it, and be caught up because it just changes too fast. The other thing that they're able to do with the attack software now is change the member IPs of the botnet by using anonymizing proxies.
So they're using rotating IPs.
So you can't latch on to
and say block this.
We call it enumerating the members of the botnet.
Yeah.
Because once you know what they all are, then you can just drop the traffic from those members.
Yeah.
But they just change as soon as you know
as soon as you've done that.
Yeah. So if I think back to, some earlier campaigns that were state actors in 2012, there was a wave of attacks on the US banking system. And back then, what we were able to do is enumerate the IPs that were members of the botnet and create big lists in order to drop a large portion of the attack traffic. And you can't do that anymore because the members just change.
I've got to step a second and go personally. What about our own personal networks? I mean, is that those kind of attacks, same kind of principle? Not that we would typically be subject to the denial of service, but they use the same techniques for that?
So interestingly, you see people in online video games, they will be playing and it's very competitive.
Yeah.
And they will use the same kind of attack against their opponent in order to stop
to block them so that they can win the game.
Yeah. So we see a bit of that too. And those big peer-to-peer networks that the game companies operate, that's a known problem on them. And this is something that a lot of typically younger people do to each other.
And they learn to do it and for their purposes, it's a gaming thing. So there are tools out there. You can essentially buy them. I mean,
you can get the tools on GitHub now. Some very sophisticated attack software.
Wow.
You can just, it's not in some dark place on the internet anymore. It's just right out in the open. There are services that you can rent access to a botnet for $5 a month. And you can run attacks against whatever you want.
$5 a month.
Yeah, and they run campaigns where they'll attack known large targets. They advertise it on Telegram, and it will say, here's an example of this, And so if you've taken something big down or impacted it in some way, then it's going to encourage more people to use that service. And it's priced very moderately. I mean, we're talking pennies for generating very, very large cyber attacks.
Wow.
Yeah,
and you talked about state actors. That's obviously what I would call countries.
Yes.
That kind of approach. That's I'm going to say predominantly government. Focused in that area. But healthcare has become. Well, maybe it's not become. Maybe it's always been a target. I don't know where you perceive that on the spectrum of attacking.
So there was a large campaign in the first half of 2023 by an actor called Killnet.
Yeah.
Against the U.S. and Western healthcare sector. And they used this attack software we've been talking about that generates a large encrypted flood to attack a number of healthcare entities. They advertised the campaign in advance, and they did a fair bit of damage. And healthcare now, post-COVID, means that you need your internet connectivity to be able to deliver patient care.
Right.
So it's no longer this crime that sort of doesn't have a victim in the same way. There was always an economic motivator.
Right.
But now people who don't have access to their doctor or physician can be impacted in other ways that are...
So why is that the case? I mean, what's their motivation if it's not economic?
To draw attention to their cause or to create chaos with their enemies. It's terror.
Right.
So the same kinds of things.
So it's not always for financial directed activity, and that the collateral damage of this is essentially associated with industries like healthcare, because obviously they're high profile, very significant, and would create a lot of angst within the population.
Yeah. Inavailability of medical services will create concern and large amounts of panic in the community as it happens and gets bigger and bigger. And post-COVID now, everybody interacts with their healthcare in some way digitally.
Right.
So it becoming suddenly unavailable due to something like a DDoS attack is a problem. So where this sector may not have thought the same way about that sort of thing in terms of how they invest their cybersecurity dollars, it's become a much bigger concern.
So we've talked a lot about the negative, the challenges. You talked about the SOCs, the command center, and I'm guessing there's some technology, AI, to combat that. Essentially, it's battle of the bots in some respects. What are we doing? How are you sort of approaching? I mean, this feels like a pretty challenging problem.
There's definitely an escalation, especially now that you can use AI to improve your tool set.
Right.
So where we used to talk about people who had access to things like scripts they could repurpose.
Script kiddies.
Yeah. Now we have actors who can use tools like Wolf GPT to write code that is new exploits and attacks. And they can create their own attack software to a reasonable degree and then debug it, and suddenly they have a super weapon. And a lot of that happens, and you see continued refinement because, again, the tools are on GitHub, and there's a whole community who's working to improve the tool set,
right,
and to expand the use cases it can be used in. So it's not just a DDoS attack that these tools will generate. It will do account takeover. It will attack your APIs, anything that really is a target out there. So when you think of your infrastructure, you're just one target, and your enemy is going to go after it in so many different ways. It's not just a DDoS attack anymore. They're going to try a bunch of web exploits. You can even use these tools now to generate zero-day attacks within hours of a CVE being published. So, to a high degree, when we've seen quite a bit of that.
So what's your guidance to folks that are living this world trying to provide services? And let's focus on healthcare. We're at a healthcare conference. How do they approach this? What should be their strategy to deal with this?
Well, the good news is that
there is good news? Oh, thank God.
Yeah, there are answers. We provide a number of services
right,
in the application security space and in DDoS mitigation. Generally, these things are best consumed with some sort of cloud approach. Right. So you'll insert your vendor of choice between you and the rest of the internet,
right,
and deploy the defenses as you need them. There's a number of very sophisticated
Do you
solutions.
think a facility can take this on themselves and staff up appropriately? I mean, I know that you obviously have a biased response, but, is it possible?
Having been at DDoS for a long time, what you need is people who are in the fight all the time. So you don't just need a vendor. You need one who is very busy.
Yep.
So, and you need engineers in the SOC who are constantly fighting attacks. I remember days when it would take us roughly a year to develop an engineer from, just started in the company to is proficient in mitigating attacks.
A year, right?
Piloting it on their own and quarterbacking that fight.
Yep.
It can be improved a lot now because you can use some very sophisticated tools to suggest countermeasures.
Yep.
Machine learning is your friend here, and also various uses of generative AI to understand the efficacy of a countermeasure. So you can make SOC engineers productive a lot faster now.
Right.
And that's one of the things that we have really put our minds and development efforts into. But there are answers. Find a cloud provider who's a fully managed service, because no matter how much money, time, resources you have, if you're not in the fight all the time, the engineers don't stay good at it.
I mean, to be clear, that's the same as medicine. If you want to have a procedure done, find somebody that does a lot of them, because then they're going to be really good.
You're a doctor. You want a doctor who does a lot of work.
Entirely the right principle.
Yeah.
Unfortunately, as we do each and every time, we've run out of time. Just remains for me to thank you for coming on the show. Fascinating. I think obviously equally terrifying, but there are solutions and help available. Thanks for joining me on the show today.
Thank you. Appreciate it.